All right, let's talk about these action potentials. So focusing on the SA node and then moving through that heart muscle. So again, when we talk about systole and diastole, we really are focusing on the ventricles. So systole is contraction, diastole, like as in dilating, is muscle reaction. So for our heart cells pacemaking, so our regular signal, which is called our sinus rhythm, that's our normal heartbeat triggered by the SA node. So again, because of the input from the parasympathetic nervous system using our vagus nerves, our resting heart rate's between 70 to 80 beats per minute. Again, you do want to go towards those lower numbers in 70s and hopefully even 60s if you're more healthy. Okay, you don't have to always fire from the SA node. You could have what's called a ectopic focus, where you have a firing from other than the SA node. So this is a good thing, because if your SA node is damaged, then you're able to still fire off a action potential. So for example, firing from the AV node, which is called your nodal rhythm. So that one's about 40 to 50 beats per minute. That's essentially the basic bare minimum in order to keep you alive. So for our SA node, so this is where our pacemaker cells are. So those pacemaker cells do not have a stable resting membrane potential. So their sodium channels are a little leaky. So in our cardiomyocytes, we start at a negative 60 millivolts with that slow inflow of sodium into the cell. So positive charge going into the cell, causing a gradual depolarization. Eventually, you're going to reach threshold, just like with your other cells, and that is of negative 40. That causes our voltage gated. So change in our voltage opens up that gate. So that opens up our voltage gated calcium and sodium channels. They now are open, and so we're now in our first section, which is depolarization. Eventually, you're going to also go into repolarization, and this is just for our pacemaker. So when we talk about our cardiomyocyte action potentials, I want you to focus on the regular cells. In our pacemakers, there's a piece that, in our regular cardiomyocytes, our regular muscle cells, there's an extra piece that you have to learn. You don't have to know the action potential for a pacemaker, which is what this is. So, same thing, we have our depolarization, then potassium leaves the cell causing repolarization. So that positive charge leaving out, becoming more negative on the inside of the cell. So when that action potential goes off, it sets off the rest of your heartbeat. So that action potential leaves our SA node and travels through the rest of the atria. So typically, because of those leaky sodium channel, it fires about roughly every 0.8 seconds. So a regular resting heart rate at 75 beats per minute. Again, depending on your health levels and cardiovascular fitness, ... Okay, so here's what a pacemaker action potential looks like. So our inflow of sodium, so our gradual depolarization, we're hitting threshold. We have our depolarization, our repolarization, and then start this process all over again, triggering a heartbeat every time. So once the signal moves from our SA node, so from our pacemaker region, it's going to stimulate both atria to contract at the same time, eventually getting to our AV node. So after it's passed through the atria, that signal goes to the AV node. So in that AV node, it slows down the signal a little bit, so it's going to delay the signal for about 100 milliseconds. That allows for those atria to contract and fill the blood into those ventricles at the bottom. So as the signal moves through our AV bundle, or also called the the bundle of His, so that middle section. No! All right, so our signal is going to move from our AV node through our AV bundle down towards the apex, and then move through our muscle tissue using the subendothelial conducting network, eventually targeting all of our ventricular muscle or myocardium, causing them to contract in together. So this is our ventricular systole. So going from the apex at the bottom throughout the rest of the heart. So going towards that base. So again, if you remember earlier, the muscle arrangement, the orientation of the muscle cells is in a spiral pattern. So it's kind of like wringing out a towel. So starting from the bottom, pushing the blood up toward the base where we have the connections for our pulmonary trunk and our aorta. Okay, so let's focusing on our cardiomyocytes. So this is the action potential that I do want you to learn. So cardiomyocytes, they have a stable resting membrane potential of about negative 90 millivolts. So they have to be actually stimulated, unlike your pacemaker cardiomyocytes in the SA node. So we have 3 different phases of a cardiomyocyte action potential. We have depolarization, plateau, then repolarization. So we have 3 different sections to learn. So we start off with depolarization. It's a very quick, very fast section. So once you're stimulated, voltage-gated sodium channels open. Sodium, the positively charged sodium, comes in, quickly increasing the charge on the inside of the cell to positive, peaking at around at positive 30 millivolts. And then those gates close up. Our next phase is the plateau phase. So this is going to keep us at this high positive charge. So we'll have calcium continuing to come into the cell. That's going to maintain our contraction to allow for blood to be pushed. So either it's blood being pushed from the atria to the ventricles, or allowing for time for that contraction to be sustained to push blood from our ventricles to either our pulmonary trunk or our aorta. So that calcium coming into the cell, positive charge coming into the cell, keeps our action potential at that positive plateau. It also comes in so it can bind to our regulatory protein. So if you remember from chapter 11 where calcium comes in and binds to a regulatory protein, we're binding to troponin in our cardiomyocytes for our contraction. Then our last part of our cardiomyocyte action potential is our repolarization phase. So we got to go back to where we came from. So our calcium channels are closed. Our potassium channel are open. So potassium goes out the cell, being repelled out the cell from the positive charge, just like with the other ones. And as that positive charge is leaving the cell, it makes the inside of the cell more negative, and eventually you go back towards your resting membrane potential. For your cardiomyocytes, to keep them from just contracting out of control, it does have a very long refractory period, so preventing your heart contraction to build on each other, unlike with your regular skeletal muscle. So you won't have a temporal wave summation where it just kind of builds up, and you also don't have tetanus where your muscle contraction just contracts and just stays there and doesn't relax at all. Okay, so here is a drawing out of our cardiomyocyte action potential. So again, we have our depolarization, sodium coming in, our plateau, so we're staying positive with calcium coming into the cell, repolarization where our potassium is going out the cell, making the inside of the cell more negative, and going back down to rest. So the red line is for our contraction. So again, just like with skeletal muscle, calcium comes in, binds to the regulatory proteins, and so allowing for that contraction, allows for enough contraction and length of time for the contraction, and then eventually goes away. Okay, so looking at all this electrical activity, we can actually record this using a electrocardiogram. So you will Here it referred to, at least kind of new vocabulary, as a ECG. The old vocabulary is EKG. I'm probably going to slip up and call it an EKG, but the new term is now ECG. So we're able to take all these action potentials of our firing. They're detected, they're amplified, so we actually can see them. And we actually can see a pattern and see if something is wrong. So we do have a normal pattern. If you ever looked at some of those tattoos that happen, yeah, after you've learned this, you realize, ooh, if that was someone's actual heart rate, they'd be in trouble. Okay, so this is what it actually looked like. So just looking at one section of it. So one atrial contraction, ventricle contraction. So each of these pieces has a section to it. And if you sing the alphabet song notes, so the, I guess, American version of the alphabet song, that helps you to remember where all your little peaks are in your ECG wave. During Connects, you also will do this, not as heavy as it used to be. So if you've ever taken this class before we switched to 9th edition, it's a lot better than it used to be. So not as absolutely boring and time consuming as you used to do for that ECG lab. Okay, so with our different sections, we have a P wave. Oops. Nope. Okay, we have our P wave, our QRS spike, and our T wave. And then we also have little sections where we're looking at timing of stuff, going, for example, like our ST wave, looking at that, our ST segment, or different intervals of time. So here, there's a multitude of measurements that you can look at between different sections. So again, the way to remember this is using the alphabet song. So it's like the notes or pitch in that song where it's like P, Q, R, S, T. So again, you also have to be musical to get this, but the notes in that song help you to remember where those little pieces are. So that's why they're those notes for that, or letters for those different sections. Okay, so let's look at this P wave first. So this is where our SA node fires, so our pacemaker. This is also where our atria depolarize and contract. So just in this little P wave, very quick section of time. Our next is our big QRS complex. So the reason why the sucker looks all like freakazoid and spiky and large is because of the larger ventricular muscles. So this is when the ventricular muscles depolarize. And again, it's weird looking because of the different sizes in ventricular muscle. And because it's so large, it masks atrial repolarization. So we depolarize our atria here, we repolarize it here, but we can't actually see that signal because this is when our ventricles are depolarizing and it's a lot larger signal. The next one is our ST segment. So this is when our ventricles are actually contracting. So this is our plateau in our cardiomyocyte action potential. So this is where that calcium comes in, binds to troponin, allowing for the muscle contraction. And then lastly, we have our T wave, which is our ventricle repolarization and ventricle relaxation. Okay, so here is a odd looking cartoon version, but looking at our different sections. So P wave, atria depolarizing and contracting. So that's what it's showing here. We can see a little dimple into the heart. And then we have our QRS spike. So this is where our ventricles are starting their depolarization. Our atria are repolarizing during this section. But again, we can't see it because of this stupid spike is so big. Okay, so rest part of our QRS spike, we have our ventricles. They fully are depolarized and they start their contraction. So during our ST segment, so this little middle piece here. And then T wave, that's when we have our ventricles going through repolarization and then fully done at the end of that T wave. Okay, so we have a normal ECG. Now, of course, if you look at an ECG and then you're also going to see like other background noise, but you're focusing on those waves. So, when you've done a fair amount of them, you know how to ignore the outside waves. Plus, the stuff in the hospital, they have so many different leads so that they can cancel out and get rid of a bunch of background noise too. And then, of course, there's some software that might help you a little bit. Anyway, so if you have a abnormal ECG, so they have a normal up here, so that's what it should look like. But then you have different other patterns, which are fairly obvious on what they look like. Did I not put that picture in there? Okay. So some of them where we're missing spikes, some of them where they're just stuff is funky. So when they're doing the ECG, they're looking for what has deviated from the pattern. And we're at 15 minutes. Let me just do a sec. Nope, this is a whole nother video for it, I guess. Pressure, close, different phases. You know what? I'm going to put these in these last few minutes. Just this section, I think. Yeah. Okay. Let's go to that. Let's do this. No, don't do that. Okay. So, and I'm only doing this because it matches with our ECG and what happens. So, I'm trying to stick this with other stuff that's learning and going with it. Okay, let's move. Okay, so our cardiac cycle, our contraction and relaxation of all 4 chambers of the heart. Okay, so we're going to be looking at our blood flow and as stuff contracts, it tracks and relaxes. So, and we'll cover this concept in our respiratory chapter as well. So the reason why we have the contraction is to build up pressure in one area so that our blood can flow down its pressure gradient from a high pressure to a low pressure, and therefore causing the movement of the blood. We can measure this pressure with a sphygmomanometer, also called a blood pressure cuff, and it's measured in millimeters of mercury. When we do respiratory stuff like air, that's actually measured in millimeters of water, so a little easier to push around. Okay, so the concepts of pressure. So here's a syringe. If I cause more pressure, this first one is increasing of the volume. So here we are pushing up the plunger upwards. We're causing an increase in volume in this chamber. So because we have less volume, we have less pressure, and that's going to cause this air to move from here, or if it was in a little like cup of water or whatever, it's going to draw stuff into the chamber on the inside. If I push down on the plunger, I'm creating less volume in that chamber. That's creating more pressure because you're all like cramped in this little tiny area. And because there's more pressure, that air, the blood, whatever, is going to move from an area of higher pressure in the smaller chamber out to the area of lower pressure. So same thing with the heart. You increase volume, therefore decrease pressure, leading blood flow into an area. So for example, our atria, when we're receiving blood, the muscles are relaxed with a nice large volume that decreases the pressure inside those atria, allowing for the blood to flow down its pressure gradient into the atria. And for example, if you are contracting atria or ventricles, moving the blood somewhere. When you decrease the volume, it causes an increase in the pressure, and so the blood is going to flow down its pressure gradient from the area of higher pressure, where you have a small amount of space, to the area of lower pressure, where you have a larger amount of space. So this is the same thing we're going to do when we deal with our lungs for our respiratory system. So those heart valves, showing how they work. So again, when our AV valves are open, our ventricles and papillary muscles are relaxed. So we have larger volume space here, less pressure here. And so the valves are allowing for blood to go from our contracting atria to our ventricles, so going down their pressure gradients. Here, where the AV valves are closed, you have our ventricular muscle is contracted. The papillary muscles are contracting, pulling on those chordae tendineae, so those heartstrings, keeping our flaps closed, so our little parachutes. And that way, when the ventricles are squeezing blood and moving it toward our pulmonary trunk or our aorta, the blood is going to push past those semilunar valves and go in that direction and not back into the atria. Okay, semilunar valves. So, when our ventricles are contracting, our blood is just able to push through, just like little saloon doors. And again, ventricles are contracting, less volume, which increases the pressure in those chambers. So our blood is going to flow down their pressure gradients into our pulmonary trunk or our aorta. And then when our ventricles contract and our blood flow kind of falls back a little bit, part of this is gravity a little bit. Again, our semilunar valves, they have that curve to them, and so they're going to flap down on each other, closing off, preventing the blood from either going into our right ventricle or left ventricle. So when these valves flap closed, that's when you have a heart sound. So the process of listening to heart sounds is called auscultation. So that's what you do with the stethoscope. So most adults you'll hear are two different heart sounds. So we have S1, which is the lub sound, and that's our AV valves closing. And if you're nursing, you do need to know this. The second heart sound, respiratory especially probably, second heart sound is the sharper dup sound. So that's the second one. If you are younger, there's also other sounds you can hear. So this cartoon actually goes through our different sounds. So when they close, you can actually hear the actual different sounds. So they're describing that in the cartoon. So first heart sound, S1, is the AV valves closing. The second heart sound is the semilunar valves closing. Okay, so with our contraction and relaxation and our blood moving and where's going who, where, and there. So there are, and again, we're focusing on the ventricles because they're the important ones. So we have 4 phases of our cardiac cycle. So our movement of blood through the heart. So of course, our first stop is those atria. And then our atria are going to first send us blood to the ventricles. So this is our ventricular diastole. So our ventricle muscle is dilated. So that's our first phase. Isovolumetric contraction. So iso meaning same, volumetric meaning the same volume. So this is when your ventricle muscle is in systole. So they're contracting, but there isn't a pressure difference, and so you're not going to have any blood flow moving through those. Ventricular ejection. So our contraction of our ventricle muscle, so our systole, is enough to create that pressure gradient. So we have decreased the volume in the ventricles, we have increased the pressure in the ventricles, so the blood is going to flow down its pressure gradient into our pulmonary trunk and our aorta and being ejected out of our ventricles. And then our last one is isovolumetric relaxation. So iso meaning same, volumetric for volume. So that our ventricle muscles are relaxed again, but there's no blood flow movement because there's no difference in pressure, and so you don't have any movement of blood yet. So we can complete this whole cycle actually in less than a second. So here's the kind of details of it. So our first phase, ventricular filling during diastole or ventricle relaxation. So the muscles are relaxed. They're allowing blood to flow into. We have that pressure difference. So again, high to low pressure from the atria to the ventricles. You don't have to know how the different phases happen, but they do. There's kind of like how you squeeze a mustard bottle, and you have this kind of like instant squirt push, and then it kind of phases off. Same situation. Second phase, isovolumetric contraction. Iso, same volume. So your ventricles are contracted, but no blood is moving. So in this phase, there's your QRS complex. This is also where you have heart sound 1 because your AV valves are closing, preventing blood from going back into your atria. Again, isovolumetric, no change in the volume of blood that is moving. But the blood isn't going anywhere because there's no pressure gradient. Third phase, ventricular ejection. So we have built up enough pressure because we have reduced the volume in our ventricles. So our blood's going to move somewhere. So our blood is being ejected out of our ventricles. So this is during our plateau phase, as well as starting off our T wave of our ECG at the end of it. And then our fourth phase is finishing off our T wave, our isovolumetric relaxation. So no blood is moving, same volume of blood, everyone has the same one. This is when heart sound 2 occurs. So our semilunar valves have closed because to make sure that blood isn't flowing back into our ventricles. And then when we start this process all over again, when those AV valves open. So again, kind of like saloon doors, they're going to flap open when we have enough pressure gradient for our blood to go from an area of high pressure to low pressure and starting off our ventricular filling all once again. So roughly your cardiac cycle is about 0.8 seconds. So that leaves you with a resting heart rate about 75 beats per minute. Again, depends on your heart health as well as your activity. Okay, so this actually puts everything in one section. So knowing what happens in each section of our cardiac phases. Is your ventricles in systole or diastole? What part of the ECG are you at? So there's also color-coded with the ECG at the above. It's just stretched out, so it kind of makes more sense. What's happening with your action potentials for your cardiomyocytes? What's happening with the muscles of your muscle contraction? What's happening with your pressure gradient? How is that affecting blood movements and your heart sound? So all of that all in one table. And that's why I connected it to the ECG section. So yeah, a little longer video, but necessary. Okay, so this is actually every little thing, like looking at your heart sound, your ECG, blood flow, contraction, all that stuff. You don't have to know all of that, just that last little table that helps. That works. And that's just, it's stretched out. Blood flow changes, don't have to know that for the test, I'm going to skip that. Blood flow failure, don't have to know that, so I'm going to skip that. Or at least for our, this test. So they're showing, end up causing edema or swelling in the lungs or swelling in the tissues. If those don't work out, I'm actually going to tack this last little piece because there's only like 3 more questions in the study guide. So looking at our pulse as well as baroreceptors and chemoreceptors. So looking at cardiac output, I'm just going to briefly explain this one. So like depending on your activity, you're going to have varying how much blood is being pumped around. So depending on if you're exercising, it's going to be a lot more. Duh. I'm going to ignore that. Okay, so with your pulse, so how many beats per minute? You can touch the person like a superficial or more surface artery, either carotid artery in the neck or the radial artery on the wrist. And you will have to do this with a partner in nursing school, and you have to get within like 5 beats per minute with your partner as you're checking someone, so you're going to practice this a lot. So again, different stages of development, different resting heart rate. Okay, so that's, I'm going to skip that, but these are things that can affect your heart rate in conditions where it is messed up. I'm going to skip that because it's not on the test. Again, stimulate the heart through your sympathetic nervous system, inhibit your heart rate, so slow it down using your parasympathetic, so same thing there. I'm going to skip, that's just showing how different things that can affect it. Not on the test, so I'm going to skip it. Nope. Okay, here we go. This is what I needed. Just Just making sure baroreceptors and chemoreceptors. Okay, so last part of your study guide, baroreceptors versus chemoreceptors. So baroreceptors are pressure sensors. They're found in your aorta and as well as your internal carotid arteries, so going toward your brain. So making sure you have a good enough pressure for nutrient delivery, but not so strong that you would damage blood vessels. So if it detects, and this is a negative feedback loop, if it detects a decrease in your blood pressure that's too low, you increase your heart rate, and therefore, so we have our signal into our brainstem, we have the stimulation of our heart, so using our sympathetic nervous system, increasing the heart rate, more blood coming out, so more blood in the same volume of space, that's going to increase that pressure and therefore get it back up. If there's a detection of a decrease in heart rate, then again, reflex feedback loop where signal to your brainstem, causing a decrease in heart rate, less blood volume in that same, those two different blood vessels, and so less volume of blood, less blood pressure. Last one, chemoreceptors. So these are going to detect chemicals. So the ones that they detect are our blood's pH. So we're actually going to do a whole chapter looking at that. Looking at our blood carbon dioxide levels as well as blood oxygen levels. So detecting that. It's more so a function of respiratory control. So changing how much we breathe in and out can actually affect all of this. We're going to get to that carbon dioxide and water. What is that thing? Equation eventually, and it actually can affect your blood pH as well. Okay, but you can adjust your heart rate due to that. So increase in heart rate when your carbon dioxide levels are too high. So for example, what the point is to get rid of the carbon dioxide. So increase heart rate, they're tied together. That increases your breathing rate and it gets you to breathe out that carbon dioxide, and therefore increasing your pH and getting you away from possibly having acidosis. Also respond to low oxygen, so slow down the heart, slowing down your respiratory and helping you to take good deep breaths in, bringing a bunch of oxygen in, plus it helps to slow off delivery of oxygen to your tissues, as in, hey, let's make sure everyone gets what they need. Okay, but again, negative feedback loops. Okay, and the rest of this is just other stuff that's not on the test, and we'll get to this in exam 9, whatever that chapter is, talking about our changes in our ions and how that affects stuff, but that's not on this test. So this is just looking at your heart volumes and the effects on the contraction strength of the heart and different natural medicines that we use, like for example digitalis, which is that flower there, can be used for like people who have like a weak heart and stuff. Okay, so again, different functions of ions that can affect it, but again, it's not on your test. So that is the end of that. So next time we'll start with chapter 20.